Hi, my name is Elad, and the title of my presentation is The Impact of High-Power, Short-Duration RF Ablation Strategy on Long-Term PVI Durability. I am presenting this study on behalf of my colleagues from the Beth Israel Deaconess Medical Center in Boston, and following this presentation, the full manuscript will be available at the JACC website. So what is the rationale for high-power, short-duration ablation? This strategy was developed not just to reduce the ablation time, but mostly to improve pulmonary vein isolation by reducing the effect of catheter instability inherent to moderate power, moderate duration ablation strategies. In a preclinical study that we published 2 years ago and studied the biophysics of high-power short-duration ablation, we found that the component of resistive heating is increased while the component of conductive heating is reduced, offering advantages for ablation in the left atrium. High-power short-duration ablation resulted in wider lesions, more continuous lines, with less incidence of gaps, and reduced incidence of collateral damage. While high-power short-duration ablation strategy may improve the acute outcome of PVI, the effect of this strategy on long-term lesion durability and its utility for linear ablation such as CTI, mitral, and roof lines have not been studied. Therefore, the aim of this study was to compare the long-term lesion durability between high-power short-duration and moderate-power moderate duration ablation for the treatment of AF, including PVI and linear ablation. This was a prospective single-center study that included 112 patients with paroxysmal or persistent AF undergoing first-time PVI plus additional lines using high-power short-duration ablation strategy. High-power short-duration ablation settings were 45 to 50 watts for 8 seconds in the posterior wall and 45 to 50 watts for 15 seconds in the anterior wall and septum. In order to avoid potential stim pops, impedance changes were monitored. A steep initial drop or decrease greater than 15 ohms prompt reduction of power or termination of ablation. Esophageal temperature was monitored using a single thermocouple esophageal probe. Linear ablation, including roof line, mitral line, and CTI, were performed in cases of documented or suspected arrhythmias involving these sites. All procedures were performed with Carlo 3, Thermocool STSF, and a smart ablate generator with a target contact force between 5 and 20 grams. The study group was compared to a historical cohort comprised of the preceding 112 patients with either paroxysmal or persistent AF who underwent first-time PVI plus additional lines using moderate power, moderate duration ablation with similar technologies at the same center. Moderate power, moderate duration ablation settings were 20 watts for 20 seconds in the posterior wall and 30 to 40 watts for 30 seconds in the anterior wall and septum. Acute PV reconnection was evaluated by either a waiting period greater than 20 minutes, isopril infusion, or adenosine. In both groups, chronic PV reconnection was selectively evaluated in patients with recurrent AF or AT who elected to undergo a second ablation procedure. Data analysis included clinical follow-up and evaluation of biophysical ablation parameters including power, duration, impedance, and catheter stability. These were the patient characteristics. Most patients were men in their 60s. More patients in this cohort had paroxysmal atrial fibrillation, and the arrhythmia recurrence following ablation was slightly lower in the patient that underwent ablation using high-power short-duration ablation strategy. However, this did not reach statistical significance. Importantly, the proportion of patients that elected to undergo a redo ablation procedure was similar between the groups, allowing us to evaluate the durability of PVI with each strategy. This slide compares the ablation strategies between high-power short-duration and moderate-power moderate-duration ablation. The upper panel shows high-power short-duration ablation strategy in which 50 watts were applied throughout the PV. It was applied for 8 seconds in the posterior wall and for 15 seconds in the anterior wall. In comparison, ablation using moderate power, moderate duration ablation was done using 35 watts in the anterior wall for 30 seconds and 20 watts for 18 seconds in the posterior wall. Voltage maps were obtained immediately after the ablation procedure, but also in patients that elected to undergo a second ablation procedure due to recurrence. Results. 112 patients underwent ablation using high-power short-duration strategy and were compared to 112 patients who underwent ablation using moderate power, moderate duration ablation strategy. The median follow-up duration was slightly longer in the patients in the historical control group who were ablated using moderate power, moderate duration ablation. PVI, the completion of the initial encirclement, was similar between the groups. However, there was a slight trend toward benefit in the high-power short-duration ablation strategy. In the high-power short-duration ablation group, the power was obviously higher, and the RFA time was obviously lower given the strategy. The frequency of acute PV reconnection was lower in the high-power short-duration ablation group, and also the frequency of chronic PV reconnection was lower in this group. So let's compare the changes in impedance between high-power short-duration ablation and moderate-power moderate-duration ablation strategies. High-power short-duration ablation strategy resulted in steeper changes of greater magnitude. It also resulted in more frequent early termination of ablation or down titration of energy. In the high-power short-duration ablation strategy, the magnitude of impedance decrease was greater in both the anterior and posterior walls. Yet, the incidence of stim pops was similar between the groups. However, if it wasn't for the diligence of the operators looking on impedance during ablation, it is likely that the incidence of stim pop would have been higher in the high-power short-duration ablation strategy group. The total RF time was shorter in the high-power short-duration ablation strategy, so as the transpired ablation time from the first to the last lesion. The incidence of acute and chronic PV reconnections were lower in the high-power short-duration ablation strategy. This is the most important finding of this study. When we examined the mechanism of chronic PV reconnection, we found that in areas of chronic reconnection, the average power, impedance drop, application duration, and even application density were comparable to those in areas without reconnection for each heart for both ablation strategies. Since those parameters did not distinguish sites with permanent from sites with non-permanent injury, we further examined differences in catheter stability between areas that reconnected to areas that remained chronically isolated. We found that areas with chronic PV reconnection with both strategies were associated with catheter motion greater than 1 mm for at least 50% of the application duration, suggestive of catheter instability. This figure demonstrates the relationship between catheter motion and chronic PV reconnection in two representative patients treated with high-power short-duration or moderate-power moderate-duration ablation strategies. Note that in the high-power short-duration ablation, a catheter motion of less than 1 mm that was maintained for 5 seconds, as shown by the VZ tags, was sufficient to produce permanent PVI. In contrast, a similar catheter motion stability of less than 1 mm maintained for 5 seconds was insufficient to produce permanent PVI with moderate power, moderate duration ablation strategy, resulting in chronic focal reconnection at the right posterior carina. In this location, although the catheter motion was less than 1 mm for 5 seconds, as in the high power short duration ablation patient, it was only maintained for 25% of the application duration. In order to quantify this finding, we compared the catheter stability during at least 50% of the application duration between the ablation strategies. Note that the percentage of application that maintained catheter stability was higher in the high-power short-duration ablation strategy. If we compare catheter stability at a more stringent cutoff of 1 mm or less than 1 mm, it was more easily achieved with high-power short-duration ablation strategy. However, when we look on catheter stability with motion of up to 4 mm, that was fairly similar between the groups. This is because the shorter application duration with high-power short-duration ablation strategy resulted in improved catheter stability during RFA. So how does high-power short-duration ablation do with mitral lines? A total of 25 mitral lines were created, 11 with high-power short-duration and 14 with moderate-power moderate duration. For posterior mitral lines, endocardial ablation alone produced block in only 42% lines created with high-power short-duration ablation compared to 70% lines created with moderate-power moderate-duration ablation. In the remainder, ablation in the CS was required for block. In addition, high-power short-duration ablation in the mitral line resulted in frequent large and steep impedance drops requiring down titration of power in 30% of the applications. Lastly, the maximal esophageal temperature was surprisingly higher in the high-power short-duration ablation group. However, there were no esophageal fistulas. In conclusion, high-power short-duration ablation strategy resulted in improved short and long-term PVI durability and similar safety parameters to moderate power, moderate duration ablation. This improved lesion durability corresponded to a higher catheter stability during ablation, such that energy was delivered during a reduced range of catheter motion. Although no patient experienced clinically significant esophageal injury, maximal esophageal temperature was higher with high-power short-duration ablation strategy, a finding that is inconsistent with the hypothesis that high-power short-duration ablation reduces the radius of conductive heating. This requires further investigation. Thank you.